It's my honor to introduce our study. I'm Guo Runqi from Beijing Hospital, National Center of Gerontology. The title of our study is Comparing Oncologic Outcome of Heat-Based Thermal Ablation and Cryoablation in Patients with T1a Renal Cell Carcinoma, a population-based cohort study from the SEER database. According to the most recent guidelines, partial nephrectomy is the gold standard for treating patients with clinical T1a RCC. However, owing to comorbidities, renal efficiency, and advanced age, some patients require minimally invasive procedures. Thermal ablation in the form of heat-based hTA and cryoablation is an alternative strategy for older individuals and those with competing health risks. The American Urologic Association recommends TA only for tumors no more than 3 cm. The European Association of Urology guidelines states that while TA is an option for all clinical T1a tumors, CA is preferred over hTA in patients with a tumor size of 3.1 to 4 cm. The most general guidelines come from the National Comprehensive Cancer Network, which recommends all TA modalities as viable options for clinical T1a tumors of all sizes. A recent study using the SEER database explored an important dilemma regarding small renal mass management by investigating cancer outcomes following hTA or CA in patients with a tumor size of 3.1 to 4 cm. However, certain limitations should still be concerned. Local tumor excision is not only less traumatic but also not inferior to partial nephrectomy in terms of relapse or mortalities. That it may not be appropriate to merge CA or any other type of local tumor excision for analysis. Additionally, a meta-analysis comparing radiofrequency ablation with CA for T1 renal tumors demonstrated no differences in terms of primary techniques efficiency rate or 5-year survival rate. Nevertheless, most of the included studies reported shorter follow-up periods. Moreover, in a retrospective study with 12 years of experience, high technical success and local disease control were achieved for MWA and CA, and the cancer-specific survival was equivalent for clinical T1a renal masses. However, the overall power of this study may be limited by the sample size. Therefore, to address the limitation of the current study and provide a better clinical reference, we relied on the SEER database to compare the efficacy of hTA and CA in treating patients with clinical T1a renal cell carcinoma, including those with a tumor size no more than 3 cm and a tumor size of 3.1 to 4 cm. Using SEER software, we recruited RCC patients, and the inclusion criteria were as follows. Patients who had a first diagnosis between 2000 years and 2019, patients who had a clinical T1a renal mass with no more than 4 cm in size, patients with a kidney cancer confirmed by SEER recording, patients who had confirmed positive histology, and those who had TA options, including CA or hTA. As for propensity score matching, the variables included demographic information and clinical pathological characteristics. Race and pathology had p-values of less than 0.05. To reduce residue and selection bias in the study cohort, we used the PSM with the nearest neighborhood for every 2 groups in a 1 versus 1 match. The baseline characteristics of patients in the matched and unmatched cohorts were compared using the chi-square test for categorical data or student t-test for continuous data. KM analysis was used to estimate the OS and the CSS in the matched population. The fine-grained model was used for data analysis, accounting for other cause mortality as a competing risk, and the cumulative incidence of CSM and OCM was calculated. Of the 3,513 assembled patients, 1,426 and 2,087 were treated with hTA and CA respectively. Before PSM, race, year of diagnosis, and pathology differed significantly between the 2 groups. After PSM, each group included 1,393 patients with SMD values less than 0.1. In the univariable Cox analysis after PSM, hTA was associated with shorter OS with an HR of 1.17, but there was no statistically significant difference in CSS with an HR of 1.07. Patients who underwent CA demonstrated a better 10-year OS rate with a p-value of 0.009, while there was no significant difference for the CSS rates. According to the competing risk analysis, there was no significant difference for CSM rates, but hTA groups showed higher cumulative incidence of 10-year OCM. In the subgroup analysis, among patients with a tumor size no more than 3 cm, there was no significant difference for OS and CSS. Also, hTA groups showed higher 10-year OCM rate. Among patients with a tumor size of 3.1 to 4 cm, CA groups showed higher 10-year OS rate. There was no significant difference for CSM and OCM. There was no statistically significant difference between hTA and CA in cancer-specific outcomes, not only in the entirety of the PSM cohort, but also in the subgroups of patients with a tumor size no more than 3 cm and those with a tumor size of 3.1 to 4 cm. In a network meta-analysis of local recurrence and other oncologic outcomes after TA in T1b RCC, no differences were found between TA techniques. However, the limited and variable follow-up between studies made it more difficult to prove the results. Thus, a larger cohort of patients with a tumor size of 3.1 to 4 cm and longer systemic imaging follow-up is necessary. As for OS, only in patients with a tumor size no more than 3 cm, there was no significant difference between the two groups. However, several limitations should be considered when drawing these conclusions. First, this study was retrospective. Moreover, standardized specimen management, central pathology evaluation, data on complications, and early cancer control endpoints are lacking. Second, the only available information concerns the initial treatment. Subsequent treatments may have been used, however, they were not directly addressed in the current study. Third, the SEER database does not include data on tumor complexity, such as renal or Padua score, or the number of kidney tumors. These factors are associated with varying degrees of mobility and as a result may affect patient survival. Finally, the long time span may have influenced ablation techniques with a shift toward more minimally invasive and personalized patient approaches. Furthermore, better quality prospective studies with protocol-driven inclusion and exclusion criteria, appropriate controls, standardized outcome measures, and adequate follow-up are needed to confirm our findings. In conclusion, in patients with clinical T1a RCC, hTA was comparable to CA in terms of CSS and CSM, regardless of the tumor size. However, hTA resulted in a slightly shorter OS than did CA. Future large-scale and cross-regional RCT are needed to validate our findings and the impact of different TA modality on patient outcomes more precisely. Thanks for your listening.